welcome to this week's webinar session, or rather a Zoom session. We've got two talks today, one from Dr. Ernst de Vet, the second one will be from Dr. Siasana Yegani. The first speaker just briefly introduces Dr. Ernst de Vet, who is one of our consultants. He's a friend and a colleague who will be discussing the utility of multi-parametric MRI imaging and active surveillance. Yeah, thanks, Ernst.
Thanks, Sam. Good morning, everyone. Yeah, so it's quite a nice, interesting topic. I think it's quite topical. For some reason, it doesn't want to go on. Here we go. Yeah, so we'll just start off with the long-standing controversy surrounding the use of PSA for detection, evaluation, and surveillance of prostate cancer. Basically, caused the need for a minimally invasive technique to identify and risk stratify these patients. Basically, then to reduce unnecessary biopsies and identify clinically significant prostate cancer, there had been a shift towards the use of a multi-parametric MRI in conjunction with the decision-making regarding prostate cancer diagnosis and management. There's data that now obviously emerges with regards to the use of this multi-parametric imaging in detection, evaluation, as well as the surveillance of prostate cancer. Patients with low-grade and early-stage prostate cancer may benefit from active surveillance, as we all know, rather than the surgical or medical treatment that's associated with a lot of side effects and morbidity. Here we go. Yeah, so the role of active surveillance is basically to ensure that there's no progression of disease. However, active surveillance may be associated with risk of underdiagnosis. The previously assignment of risk categories and patient monitoring were based on purely on digital rectal examination, transrectal ultrasound guided biopsies, and serum PSA levels. The multi-parametric MRI of the prostate has an estimated negative predictive value of 95% for detection of prostate cancer. So yeah, multi-parametric MRI guided biopsy at the initial stage of risk stratification for newly prostate cancer may reduce the number of underdiagnosed patients, improve long-term prognosis, as well as reduce the number of patients who are overtreated, which is quite important. So for these reasons, the multi-parametric MRI had become an accepted monitoring tool for active surveillance programs. Just sort of the outline of this talk, although we've already started, I'll give a little bit of a background of active surveillance and multi-parametric MRIs. We'll have a look at the EAU data and recommendations, active surveillance follow-up protocols we'll touch on. We look at the role of multi-parametric MRI in active surveillance, which is probably the main part of the talk. We look at the limitations of current active surveillance strategies, and then we'll also look at future perspectives. So as already mentioned, active surveillance is a strategy of management of low-risk prostate cancer, and it's based on monitoring and results in treatment only if the disease progression is confirmed. Alternative management, as we know, is radical radiotherapy, ablative therapies, and then obviously radical surgery. Several protocols actually exist to determine who is good candidate for active surveillance, but none of them actually incorporate multi-parametric MRI, which is probably something that need to change. This is just to show how many protocols are available. I know for a long time we've been using the PRIAS protocol, so you can see it's clinical staging, Gleason scores, all of them obviously 6 or less, number of positive biopsy cores, all of them involved, single core involvement, yeah, etc. So PSA and PSA density is the last sort of point they look at. Yeah, active surveillance may help resolve the problem of overtreatment in low-risk prostate cancer. the implementation of a multi-parametric MRI to these patients can reduce the number of prostate biopsies, which is also good. It can refine early identification of occult higher risk disease. It can also reduce the number of diagnostic biopsies in the low-risk patients with lesions in the anterior prostate, which is always a problematic area. Using imaging during selection of candidates and disease reclassification during active surveillance can increase the diagnostic accuracy and improve the patient management and decision-making. If we look at the 2020 guidelines, I don't have access to the 2021 guidelines yet, unfortunately, but I'm sure it didn't change too much. The inclusion criteria, EIU basically had the detective consensus group that looked at active surveillance in low-risk prostate cancer. It's a multinational group, obviously, and they looked at, well, basically at all aspects of active surveillance. Selection criteria for active surveillance is limited by a lack of prospective randomized controlled trials. However, the most published criteria often include ISIP grade 1, clinical T1C, clinical T2A, PSA less than 10, and a PSA density of less than 50 nanograms per milliliter per cc. And this is sort of what everybody agreed on. However, they couldn't find any agreement around the maximum number of cores that are positive, and then also the maximum percentage of core involvement to make decisions if a patient should be included into active surveillance protocol or not. Clinical T2C disease and extensive disease on multiparametric MRI should exclude men from active surveillance. So yeah, favorable ISIP2. So in other words, patients with low volume disease, but 3+4 Gleason, also clinical T2A and not more, should be considered for deferred treatment or active surveillance. In these patients, however, the recommendation is that you do rebiopsy them in 6 to 12 months, and that would be mandatory, which is different from the ISIP1 group. 3 clinico-pathological variables significantly associated with reclassification of the active surveillance groups. Basically include PSA density, if there was more than 2 cores positive, and then the African American race. All of those are significantly associated with reclassification. There's also a strong feeling from this consensus group that men should be excluded from active surveillance if they've got any sign of ductal carcinoma, sarcomatoid carcinoma, small cell carcinoma, extraprostatic extension, or lymphovascular invasion on the biopsy itself. So yes, men that are eligible for active surveillance on a systematic biopsy alone, in these guys, a multiparametric MRI can detect suspicious lesions, and that might induce reclassification at a confirmatory biopsy. So if you only had a patient on systematic biopsies, it's actually a good recommendation that you get a multiparametric MRI prior to a confirmatory biopsy. The active surveillance magnetic resonance imaging study, or ASSIST, randomized men on active surveillance scheduled for confirmatory biopsy to a 12-core systematic biopsy, or to MRI with targeted biopsy combined with systematic biopsy, up to 12 cores in total. So they didn't do extra biopsies in the targeted biopsy group. The initial group, report showed little benefit in the targeted biopsy group. However, after 2 years of follow-up, the use of the MRI prior to this confirmatory biopsy resulted in fewer failures of surveillance, 19 versus 35%, as well as fewer patients progressing to ISIP more than 2, 9.9% versus 23 in the systematic biopsy group only. So the detective consensus group meeting agreed that men eligible for active surveillance after a combined systematic and MRI targeted biopsy do not require a confirmatory biopsy. They can go straight on to the active surveillance protocol. So the monitoring during active surveillance, the three mainstays remain the serial digital rectal examination at least once a year, a PSA count at least every 6 months, and then a repeat biopsy. You'll notice I haven't put a timeline next to that because it's a bit more complicated. Previously, they would routinely biopsy everybody every year, or certain protocols would say 1 year 1, year 4, year 7. I think that was previous, but that had changed a little bit. Reported data on sequential multiparametric MRI evaluation led to an overall upgrading from ISAP-1 to more than ISAP-2 prostate cancer of about 30%. So that's significant. And these patients had combined targeted as well as standard biopsies. So that's a significant number. Upgrading occurred in 39% of the patients who had MRI showing progression, versus only 21% of the patients who had a stable MRI. Stable meaning no sign of malignancy. So PIRAT's less than 3. In a small study of 75 men within the previous protocol who had a multiparametric MRI at baseline, 61% of them had a negative multiparametric MRI, while 26% of them were reclassified at 12 months by systematic biopsy only, which is quite significant, I would think. So the data on combination of serial multiparametric MRI and PSA as a trigger for rebiopsy is very limited. It seems that that might be, in future quite a big talking point, but the data is very limiting at the moment. So the use of this MRI and PSA changes should only, as a sole trigger for rebiopsy, you would have actually detected only 70% of patients that progressed on an active surveillance protocol. So it's still not the gold standard. And we're actually far off from that, to be honest. Patients with no visible lesions on the first MRI and a cutoff of less than 0.5 nanograms per milliliter per year in PSA velocity had a sensitivity of about 90% and specificity of 75% for progression on active surveillance. PSA doubling time, less than 3 years. This had been shown to be a less powerful indicator to change management, and the consensus are this should rather trigger further investigation and not necessarily management. So that would probably entail follow-up, obviously rectal examination, PSA, multiparametric MRI, and then biopsy, should that be the case. A clear agreement on the detective consensus meeting showed that the change in PSA, as I said, should rather lead to repeat multiparametric MRI and biopsy, and not immediately to management change. Changes on follow-up MRI needs confirmatory biopsy, and there's no agreement yet on the histo criteria, as we mentioned. So the extent of core involvement, the number of cores involved that would require to trigger a change in management. Active surveillance in prostate cancer, we've mentioned already. It's a strategy for management for patients with low-risk prostate cancer, and based on monitoring of the disease, and undertake treatment if the disease progression is confirmed. The intentional delay of intervention reduces the rate, obviously, of overdiagnosis and overtreatment. Several factors are required before you can determine if a patient or individual is suitable for active surveillance. This would include the general clinical conditions, life expectancy, possible treatment side effects, disease characteristics, and then obviously the wishes of a patient should also be taken into account. Patients sometimes just want the cancer out or treated. Living with cancer inside your body can be quite stressful. So current clinical assessment do not routinely involve any imaging of the prostate gland, so that's quite significant. So benefits of active surveillance, obviously we avoid unnecessary treatment while preserving quality of life, and then we reduce healthcare costs by doing this. The disadvantages of active surveillance, you always have a risk of missing optimal timing to start definitive treatment. The risk of tumor progression or metastases before treatment can also happen, unfortunately. Patients may suffer from anxiety, as I mentioned, from knowledge that they have cancer. And then there's the need for repeat digital rectal examinations every 6 months or every year, and a biopsy when indicated is also a disadvantage, obviously, because it leads to morbidity. The natural history of untreated low-risk prostate cancer remains poorly understood up until this day, although Campbell's has many pages on prostate cancer. So the main issue that affect potential impact of multiparametric MRI on active surveillance protocols include the heterogeneity of inclusion criteria for active surveillance, the definition of clinical significant disease, agreement about what should be understood as radiological progression, and yeah, so those are the main things we actually have to look at when you look at the active surveillance protocols. The role of multiparametric MRI in active surveillance the multiparametric MRI enables obviously increased prostate cancer detection as well as localization of the tumor, and it also leads to further characterization in terms of tumor size and stage, which we previously, prior to MRI, very rarely had that imaging available, obviously. The multiparametric MRI might be useful in 2 stages of the active surveillance protocol. First, as we mentioned, the baseline examination of a patient enrollment lead to better qualification and selection for active surveillance, and then also an alternative to follow a prostate biopsy. So this, we've already said, is not an alternative to prostate biopsy, but it can prevent a possible follow-up biopsy if all the data checks out. The 2019 update on PIRATES version 2.1 incorporates T2 weighted MRI on the axial plane and at least one perpendicular plane, diffusion weighted images with ADC maps, and then also the dynamic contrast enhanced imaging. The bioparametric MRI includes T2 weighted image, diffusion weighted imaging, as well as ADC maps, but not the dynamic contrast enhanced imaging. And it seems that this is quite an accepted method just to do bioparametric, but specific recommendations for active surveillance is still lacking in this regard. Won't touch on here. Yeah, so diffusion weighted imaging is the main sequence for tumor imaging in the peripheral zone. If you remember, and then the T2 weighted imaging is the main sequence of tumors in the transitional zone. Diffusion weighted imaging detects random movement of protons in the interstitial space. So water molecules, which is the main source of these protons in the body, move freely in normal tissue, but tumor consists of densely packed cells and an abundance of cell membranes with restricted diffusion of water. So obviously that's the reason we pick it up. A non-significant low-risk prostate cancer is a volume of less than 0.5 cube centimeters, Gleason of 6, and yeah, currently low-risk prostate cancer can only be confirmed on histology or a prostatectomy specimen. That's the only way we have at the moment to say if something is low risk or not definitively. So reclassification of prostate cancer in the active surveillance groups within 2 years is up to 20 to 30% of patients. And this is just by using the standard assessments of digital rectal examination, serial PSA levels, and repeat prostate biopsies. Most reclassifications for prostate cancer are caused by undersampling at the first biopsy rather than a progression of indolent tumor. So this indicates that the routine serial biopsies may be misleading in these patients. And this is again where a multiparametric MRI can come in and help. There's a need for method to reduce the risk of underestimation by targeting the biopsy needle to the most significant area of prostate tumor. Targeting biopsy needle onto the index lesion can reduce the risk of underestimation of prostate cancer stage. One of the main disadvantages of serial biopsies is the anterior prostate cancer diagnosis. And this is the cause of reclassification in up to 25% of patients undergoing active surveillance after 2 years. So it's that tumor that sits anterior. Our serial biopsies very rarely get to them. The 95 negative predictive value of multiparametric MRI highlights the opportunity to avoid repeat biopsies for active surveillance. Okay, so the identification of a significant prostate cancer. The MRI has a high degree of accuracy to identify significant prostate cancer. As we can extrapolate, it's lesions that are bigger than 0.5 centimeters. It's Gleason 7 and above, extraprostatic extension. Puch et al., it's already back in 2009, showed that histology of whole mount prostatectomy specimens, that the sensitivity and specificity is 86 and 94% respectively, with a negative predictive value of 95%. So this is already 12 years ago. The correlation between ADC values and histological Gleason grade has been shown and proven. Lower ADC values and higher signal on diffusion-weighted imaging correspond with more dense structures of less differentiated cancers. In other words, more aggressive cancers. Diffusion-weighted imaging has the ability to distinguish between low-grade, intermediate-grade, and high-grade prostate cancer. They have found that baseline ADC values is an independent predictor for unfavorable findings of control biopsy and also time to requirement of treatment of prostate cancer in active surveillance. So MRI is a tool for enrolling patients for active surveillance programs, as well as monitoring method for patients already under active surveillance. Patients under active surveillance who have a suspicion of malignancy on multiparametric MRI has an increased risk of upgrading of Gleason score compared to those who did not have the imaging findings, less than Pirate's 3 lesion. Vargas et al. In 2012 suggested that, found that low-risk prostate cancer on MRI had a negative predictive value between 0.96 and 1 for upgrading to a higher risk prostate cancer. So these patients could have avoided repeat biopsy. The inverse applies. So the high-risk patients for clinical significant prostate cancer on MRI had a positive predictor value of between 0.87 and 0.98. And these patients obviously definitely needed a biopsy or should seriously be considered for a repeat biopsy. Okay, the limitations of current active surveillance strategies of prostate cancer. So most candidates for active surveillance had, still in this day and age, unguided transrectal prostate biopsies, usually 10 to 12 transrectal needle biopsies, which led to underestimation of cancer grade in 30% of those, and underestimation of burden of cancer in 50% of patients. Systematic errors in non-guided biopsies are due to selective posterior zone sampling and inadequate transition and anterior zone biopsy. For obvious reasons, it's more difficult to get to that anterior prostate in a normal transrectal ultrasound guided biopsy. The main strength, however, of the multiparametric MRI for active surveillance is the use of the targeting biopsies, because this is much improved in the initial diagnosis. The concept of multiparametric target biopsy is a method of choice in active surveillance qualification, as well as an alternative to repetitive biopsy. However, the 3D transperineal mapping biopsy is very expensive and invasive, obviously, and it's not readily available, obviously, in large parts of the world. Yeah, so anterior prostate cancer involving obviously the anterior part of the prostate is responsible for about 20% of cases. And obviously it's difficult to biopsy these using the standard 12-core truss biopsy. So anterior prostate cancer is most often missed or misclassified tumors of all the prostate cancers. An interesting fact is the median biopsy core length between the targeted systematic biopsy versus the non-targeted biopsy in the anterior prostate cancer cases were 8 millimeters versus 1 millimeter. So there's a very big discrepancy. And this obviously leads to inaccuracies in tumor volume as well as tumor grade. So as I already mentioned, anterior cancers are the most commonly reclassified cancers, purely because of the biopsy bias and fewer and shorter cores taken from that area. This is a relatively new study in the European Urology Oncology that they basically looked at they evaluated the diagnostic performance of multiparametric MRI for disease progression in men on active surveillance. So they did a systematic review in accordance with Cochrane Handbook and PRISMA. They identified 7 studies, a total of 800 patients, and they found a pathological progression on active surveillance of 27%. The sensitivity and specificity of multiparametric MRI for disease progression were 0.61 and 0.78 respectively. So if they adjust that for prevalence of disease progression of 30%, they had a positive predictive value of 0.43 and a negative predictive value of 0.81. So if you look at that, it's not possible to supplant prostate biopsies with a multiparametric MRI in active surveillance protocols with current level of evidence. They also found that significant institutional variation in diagnostic performance of multiparametric MRI during active surveillance exists, and they recommended that active surveillance protocols must be based on local diagnostic performance rather than the international active surveillance protocols. So an interesting study I ran across, and it's from the Netherlands, if I remember correctly. They had an objective to determine the cost effectiveness of 3 active surveillance strategies. The first one is active surveillance, basically based on transrectal ultrasound guided prostate biopsy. Then patients who had multiparametric MRI as well as MR and truss guided biopsy, and the third group who only had multiparametric MRI without any biopsies. So the healthcare cost and quality adjusted life years were modeled over lifetime, and the results basically is quite interesting. The expected mean cost per man screened were €5,100 in the truss guided biopsy group, almost €6,000 for the multiparametric MRI group without biopsy, and then the cheapest of the lots were the multiparametric group who had biopsy as well, which came down to €4,800. Corresponding quality adjusted life years were higher for the multiparametric MRI group with biopsy as well, if it compared to the truss guided biopsy group, as well as the multiparametric group without any biopsy. So the conclusion was that multiparametric MRI with MR truss guided biopsy appears to be the most cost effective active surveillance strategy for men with low risk prostate cancer. So the more is better in active surveillance, in other words. So yeah, recently diverse applications of machine learning focus on imaging of prostate cancer had been described based on various algorithms. This may aid in assessment of the lesion aggressiveness, enrollment into active surveillance, detection and diagnosis of tumor invasion, and quantitative characterization of disease patterns support future possibility of substitution of the multiparametric MRI with a biparametric MRI, although we're not there yet, and this is obviously biparametric MRI is probably a bit more increased accessibility and with comparable results and accuracy of radiological interpretation with a little bit of less healthcare. So to conclude, the multiparametric MRI of the prostate is an established imaging method of value in patients requiring targeted prostate biopsy. It helps identifying higher grades and volume of prostate cancer than the plain systematic 12-core biopsy. Possible candidates for active surveillance would benefit from multiparametric MRI, which enables better initial diagnosis and reduced need for repeat biopsy. So that's the crux of the matter, is better initial diagnosis leads to better outcome. Multiparametric MRI is a valuable tool for monitoring patients already under active surveillance, which obviously again leads to a reduction in the need of repeat biopsies. Evidence-based clinical guidelines suggest that the MRI will probably become the new triage test for men with suspicion of prostate cancer. Although we're not there yet, that's probably where the future heads. And then future large-scale prospective control studies require to define precise role of the multiparametric MRI as well as the biparametric MRI in active surveillance of prostate cancer. So just the last thing to end off with, I'll just give you the recommendations from the EAU guidelines. So they suggest you offer active surveillance to all patients with a life expectancy of more than 10 years and low-risk disease. If a patient has had upfront multiparametric MRI followed by systematic and targeted biopsy, there is no need for confirmatory biopsies. Patients with intraductal and cribriform histology on biopsy should be excluded from active surveillance. If required, perform a multiparametric MRI before your confirmatory biopsy. Take both targeted biopsy, so that would be of a PIRATES 3 and above lesion, and systematic biopsy if confirmatory biopsy is performed. Perform serum PSA assessment every 6 months in your active surveillance patients, and perform digital rectal exam every 12 months. Repeat biopsy should be performed if there is evidence of PSA progression, clinical progression on DRE, or radiological progression on your multiparametric MRI. During follow-up, if MRI is negative, so PIRATES 2 and less, and clinical suspicion of prostate cancer progression is low, so low PSA velocity, low PSA doubling time, omit biopsy based on shared decision-making with your patient. And then the last thing, you have to always counsel your patients about the possibility of needing further treatment in future. Thank you.
Thank you, Ernst, for an excellent talk. I see you've done it comprehensively, which is it touched on all the important concepts and principles of active surveillance. And I saw you quoted a study by Lawrence Klotz's ASSIST trial, and you're absolutely right. It actually showed slightly different results from the ones we know from the Precision trial, in the sense that
yes,
the biopsy did not really, show much benefit in the initial stages. And apparently, that was related to the fact that it was more of a learning curve when they were doing their new technique in doing fusion biopsies.
yes.
I think the critical question now is, are we at any point that we can actually replace a protocol biopsy with an MRI with the evidence we have?
Yeah, so look, that is what this the guys, I think they're from Great Britain, they looked at exactly that question. And current evidence, no. But if you put it into perspective, so certain patients that we can, and those would be the patients that if you've got a negative MRI, in other words, if you've got PIRATES 2 and less, and clinical suspicion that there's no advancement of the disease, so it's still T1C or T2A that you had at the initial stage, and then obviously PSA is stable as well. In those patients, it's definitely a means to not do a biopsy after speaking to the patient, obviously. The real thing is, you know, if if there's anything of those parameters that is on the fence, you know, then you probably need to do a targeted biopsy. Obviously, if there's a Pirates 3 and above, and but with a systematic biopsy, unfortunately, as well. So no, we're not there yet, Sam. But I'm sure that's the future. I believe the future will probably entails a non-histology based MRI that you can say this guy's got a Gleason 7 based on MRI pictures. I'm sure, you know, with AI and, you know, computer learning, it will probably be the future. In 15 years from now, you're going to have your MRI and it's going to say, yes, you need radical treatment. And they'll push you around to the robot where the robot will take out your prostate. So that's probably where we're heading. We're not there yet, no.
Yeah, no, thanks a lot to Ernst. I mean, also came across a study at MSKCC looking at the role of MRI on patients and active surveillance. And so the role of MRI changes. And in fact, so the guys are saying the MRI progression does not really correlate, you know, 100% with the pathological changes, because they actually found that patients who actually had negative MRIs, you know, at 1 year were found to be upgraded at you know,
up to 20% of those. Yeah, I think 28% of them that had negative MRIs were biopsied and they still had progression. So yeah, it's a we're not there yet, unfortunately, but it's probably the future.
Yeah, now I must say, we just to confess that we actually do replace you know, biopsies on year 1 with an MRI, like you said, close monitoring, PSA, and everything else. Ernst, thanks so much. It's really. Do you have any questions on the floor? I mean, that's a very, very interesting topic, and like you said, it's a very topical thing these days, neurology, MRI. Any questions for Ernst? I'm not seeing any questions.
Ernst, just a quick one. Would you go with the annual biopsy or the 1, 3, and 7?
So there's not enough data to suggest which one is superior, though. The again, it's going to be risk stratified. You know, if a patient had that initial MRI that with a targeted and systematic systematic biopsy that was negative, and it's still the same at 1 year, you know, I would probably rather go with a 1, 3, 7 if need be, but again, to assess each individual case, because if you're in that protocol and there's any slight change at year 2, you're not going to skip year 2 because your protocol says so. So you just have to adhere to your triggers to investigate further, not necessarily change management decisions, but definitely to change investigation or to investigate further.
It would be an overkill to do a yearly, you know, biopsy, especially when we have MRIs these days. Very interesting question. Thanks, Justin. Another question from Lisa. There is a role of multiparametric MRI in favorable risk, intermediate risk prostate cancer in terms of deciding on active surveillance. Does it help you in deciding for those patients active surveillance or not?
Sorry, I haven't seen the question. I'm just trying. There we go. Yes, yeah, there's definitely a role for the favorable risk intermediate. So that's obviously the cases that I think I mentioned it quickly in the talk. It's definitely one of those. Obviously, it needs to be ISIP 2 at most, so it's a 3+4. But then you look at all the other factors as well. It needs to be a low, you know, that should be the only intermediate risk factor. Is the 3+4, and the rest should still be PSA less than 10. It should still be a clinical T1C or clinical T2A, and then obviously we look at the cancer burden itself as well. Obviously, things like extracapsular spread is a no-no, and then tumor volume should be less than 0.5, preferably. And then obviously you look at things like PSA doubling time, etc. And so all these add up, but there's definitely a place for the lower tier intermediate risk. Obviously, you need a proper counseled patient before you make these decisions, but it's in the guidelines. So yes, you can offer them that.
Yeah, no, thanks a lot, Ernst. Just to add on your sort of answer, it seems like at Sunnybrook in Toronto, they also use biomarkers in these patients who are intermediate risk, just to be sure that they actually have the right, the pussycats instead of the tigers in that category. Yeah, no, thanks a lot, Ernst. Very interesting topic.
Thank you.
We'll move over to the next speaker. Hi, Sia. Do you mind just putting your first slide? So our next speaker is Dr. Siasanga Yekani, who's a junior registrar.